Bismillahirrahmanirrahim. Welcome to my channel Science of Life with Dr. Yusuf. Today we are going to talk about the very common cause of death in developed world, that is the coronary artery disease. But before that, one hadith I would like to quote. हुज़ूर सल्लल्लाहु अलैहि वसल्लम ने फरमाया कि ला तक़ूमु अस्साअतु हत्ता युबअस दज्जालूना कज़्ज़ाबूना क़रीबुम मिन सलासीना कुल्लुहुम यज़उमु अन्नहु रसूलुल्लाह। ला तक़ूमु अस्साअ, क़यामत उस वक्त तक कायम नहीं होगी, यानी क़यामत कायम होने तक ये काम हो जाएगा। हत्ता युबअस दज्जालूना कज़्ज़ाबून, यहाँ तक के कुछ ऐसे 30 के करीब ऐसे अफराद जो आ जाएंगे, 30 के करीब ऐसे अफराद उठा दिए जाएंगे जो दज्जाल होंगे और कज़्ज़ाब होंगे, झूठे। दज्जाल वैसे तो दज्जल उसको कहते हैं, धोखा देने को कहते हैं, दज्जाल धोखा देने वाले, कज़्ज़ाब झूठे। इनमें से हर एक ये दावा करेगा कि वो अल्लाह का रसूल है। कुल्लुहुम यज़उमु अन्नहु रसूलुल्लाह। तो ये फितनों में ये दज्जालों का आना और उनमें से नबूवत का दावा, हुज़ूर सल्लल्लाहु अलैहि वसल्लम अल्लाह के आखिरी नबी हैं, आखिरी रसूल हैं, और उसके बाद जो भी दावा करेगा वो दज्जाल होगा और वो कज़्ज़ाब होगा। तो हुज़ूर सल्लल्लाहु अलैहि वसल्लम के फरमान के मुताबिक लोग आते रहते हैं, तरह तरह के दावे होते रहते हैं, हम सुनते रहते हैं। तो अल्लाह पाक हमें इन दज्जालों कज़्ज़ाबून से बचने की तौफीक अता फरमाए। अल्लाह पाक कुरान और हदीस के साथ जुड़े रहेंगे तो इंशाअल्लाह ताला इन दज्जालों से हमेरी हिफाजत होगी। अल्लाह पाक समझ अमल की तौफीक दे। So I am going to talk about the coronary artery disease. We discussed the coronary vessels, coronary circulation in the last lecture. As I said, the leading cause of death in developed countries is this coronary artery disease, abnormalities of coronary artery circulation, and maybe in the form of ischemic heart disease or milder form, maybe in the form of the only angina pectoris. So ischemic heart disease may be in the form of acute heart attack, or it may be in other forms as well. It is not the only heart attack only. Gradual ischemia may occur in some people. Sometimes unnoticed ischemia occurs without any pain and the heart goes into failure. Multiple infarcts may develop without any symptom, and gradually there is heart failure will occur. So angina pectoris is the pain which felt in the initial stages of this coronary artery disease, and then the acute myocardial infarction, AMI, that is very commonly a cause of death, quite a common cause of death in the developed world. So ischemic heart disease, I said, the angina in the form of angina pectoris or myocardial infarction. Usually, there is reduced coronary artery blood flow, CBF. Coronary blood flow is reduced due to deposition of cholesterol, atherosclerosis, or plaque formation because of the deposition of this cholesterol in the intima of the vessels, coronary vessels we are talking about. So there may be atherosclerosis, cholesterol deposition in the subendothelial region of those blood vessel, coronary blood vessel we talked about. Or sometimes there is thromboembolic phenomena, that is, the clot may occur somewhere else in the body, and that clot may be formed in the form of a thrombus, and thrombus may obliterate any blood vessel. So if this occurs in the coronary vessel, usually this happens, that is, in some bigger artery there is plaque and there may be some clot formation there, and we know that the blood will clot if there is a rough surface is there in the endothelium is rough. So this plaque may cause roughening of the endothelium, and there may be clotting of the blood may occur, thrombus may be formed, platelet aggregation may occur there, and that thrombus may be thrown and it may block some distal small branch of the coronary artery, may cause the acute myocardial infarction or angina, etc. This disease, ischemic heart disease, the risk factor for this ischemic heart disease is family predisposition. genetic background. It has been observed, it has been proved that this disease runs in family. So there is some genetic background. Some people have got the more tendency to those people in something wrong with something in their genes that they easily develop this atherosclerotic process, and some people they don't develop at all. Some people they utilize a lot of cholesterol throughout their life, but there is no atherosclerosis. So there is some genetic background. Family history is very positive in the ischemic heart disease. Then, addition to that, there are some factors which cause the more atherosclerotic process or which enhance the atherosclerotic process. Smoking is one of the very important risk factor. This ischemic heart disease is more common in people who are indulged in smoking or excessive smoking. Then hypertension. The hypertension also runs in families. It has got the also genetic background. So it has been observed that in people who have got the hypertension, so there may be ischemic heart disease in those people as well. And it is very common in diabetic people. As you know, diabetes is also a genetic background, genetic predisposition for the diabetes mellitus is there. So that diabetes itself is a metabolic disorder which causes abnormality of the cholesterol and fat metabolism, carbohydrate, protein metabolism, and that may cause the more deposition of this formation of plaque. Atherosclerosis is more in diabetic people. Then, of course, increase utilization of cholesterol. That is excessive intake of lipids, lipid utilization, or the saturated fatty acids. They cause the formation of more and more cholesterol, which may be deposited, and atherosclerosis may occur. And then, of course, the sedentary lifestyle. That is lack of exercise. Physical activity is very important for the prevention of this ischemic heart disease. So lack of exercise, sedentary style of life is also a risk factor for the development of ischemic heart disease. And then, of course, tension, anxiety and tension. People have got their sympathetic stimulation and etc. And it may cause the anxiety also is a very important risk factor in the ischemic heart disease, development of ischemic heart disease. Ischemic heart disease, sometimes, as we have said, it may be small ischemias, different ischemias, the small vessel blocked, and there may be no pain at all. Unnoticed angina may occur. And not angina, unnoticed infarctions may occur. Unnoticed ischemia may be there. But if there is some pain, the initial stages, there is angina pectoris. Pain felt in the angina is described as the discomfort in the chest, during effort. Usually, angina occurs when the person is exerting more exercise or physically active or uphill when the person is going. So in effort due to the decreased coronary blood flow, there is atherosclerotic process going on, but during rest that blood is sufficient, but when the person performs activity or effort, then the more blood is required for that, and those narrowed coronary vessels may not be able to supply the sufficient amount of the blood, and then the angina, the person may feel that discomfort or pain. So this is transient myocardial ischemia. That is, at rest there is no ischemia, but when the person becomes active, there is more requirement of the blood for the more utilization of oxygen and metabolism in the heart, and then that blood may not be sufficient, and the person may feel the pain. That is angina. This angina, patient complains of tightness. This pain is not as a headache. It is a tightness and sight of discomfort and in the middle of the chest, retrosternal. Behind the sternum, the person feels pain here, discomfort here, or of tightness here for a few minutes, and pain often radiates to inner side of the arm. It may radiate to the shoulder or inner side of the arm because of a specific nerve supply. So this is angina pectoris. It is relieved Pain is precipitated by effort and it is relieved when the person rests. रेस्ट करने पे ये खत्म हो जाता है एंड एफर्ट पे ये पेन आ जाता है. सो दिस इज एंजाना, द अर्ली स्टेजेस ऑफ द ischemic heart disease. Then if the blockage of the vessel is too much, then there may be some damage to the myocardium. In angina, only pain is felt, there is no damage to the myocardium. But if there is some damage to the myocardium, that we term as the acute myocardial infarction. Death of the tissue may occur. It is due to the obstruction to the coronary blood vessels. At least 75% of the lumen may be blocked. More than that, 75% of the lumen, coronary artery lumen, is blocked by the thrombus or plaque. It is blocked or thrombus is blocking it. As AMI is the leading cause of death in developed countries, as I said previously. So these are the coronary vessels. So blood is flowing, but if there is deposition of cholesterol, this is normal blood vessel, and this is plaque formation, and the vessel has been narrowed. It has been seen. Narrowed vessels, there may be some blockage. So this is narrowed vessel plaque, and this is the normal vessel. So gradual deposition of this cholesterol in the intima of the vessel results into the narrowing of the vessel, and blood flow is reduced. This is again a vessel where this is the plaque. This inside the vessel, there is deposition of the 50% of the plaque has occurred in this vessel, for example. So there is blockage, there is deposition of this lipid-rich core of plaque. This is usually cholesterol. It is deposited. So the atherosclerotic process is the cause of this coronary artery disease or ischemic heart disease. Acute coronary occlusion, most frequently in the atherosclerotic vessels, acute occlusion occurs. Atherosclerotic plaque may cause local thrombosis. There is plaque, there is maybe some roughening over the endothelium may be roughened in that area, and that rough area is the that focus for the deposition of the platelets are deposited, they aggregate there, and the thrombus formation are the cause the local thrombosis, and this atherosclerotic plaque may have broken through the endothelium. Sometimes atherosclerotic plaque, this ruptures the endothelium, and that causes very quick thrombosis, and the acute heart attack may occur. And an embolus may be formed from the bigger vessel, and it may block a smaller vessels. वहां से टूट के smaller branch को block कर सकता है, and that will cause the acute myocardial infarction. Now, local vascular spasm may occur sometime. What we are talking about, the acute attack कैसे हो सकता है? So there may be atherosclerotic process, and then plaque may be completely, thrombus may be formed, and it will cause the acute attack. And sometimes it is local vascular spasm at the site of plaque. Plaque, where this plaque is present, I'm going back. So where this plaque is present, this is rough surface, and sometimes there is the acute, this plaque is irritating the muscles. This deposition may cause the irritation of the smooth muscles, and they may constrict. That is the plaque. At the site of the plaque, muscle may be stimulated by this plaque, and this local vascular spasm at the site of the plaque, direct irritation by this plaque may cause the more constriction, and then acute attack may occur. So direct irritation or local nervous reflexes, sometimes this plaque irritates, and the nervous mechanism is also involved for the contraction of the smooth muscles, and the smooth muscle will contract, and they will obliterate the blood flow, and it will causing severe coronary constriction and causing the acute myocardial infarction. The blood vessels we talked about in the previous lecture, these coronary vessels, almost no anastomosis in larger vessels. There is no collaterals, anastomoting or branching which join together. There is no anastomosis. Smaller branches, there may be some anastomosis. We are going to see the diagram. So degree of anastomosis is critical for the outcome of coronary artery disease. If anastomosis, we know with the exertion, with the performance of the exercise, with the ischemia, there is development of the new blood vessel, angiogenesis may occur. And if the anastomosis occurs throughout the life, and in the elderly people, a lot of smaller collaterals, new blood vessel may have been generated there, and if there is some blockage of the vessel, anastomosis is there from the other vessel, and there may be no infarction. So this degree of anastomosis is critical for the outcome of this ischemic heart disease. If there is excessive anastomosis has occurred, new angiogenesis has occurred, so acute myocardial infarction may not be fatal. So slowly developing atherosclerosis may cause the development of more and more collateral anastomosis. Angiogenesis may occur if the slowly developing atherosclerosis. It causes a narrowing of the vessel. There is some ischemia, and that ischemia causes the development of new blood vessels. We talked about when we were talking about the long-term control of the local blood flow, angiogenesis, etc. will occur. So if there is slowly developing ischemia, collaterals do develop, angiogenesis occurs, and there is a lot of new collaterals are formed, and AMI may not be that serious, and that is the cause you must have observed, that is if heart attack occurs in young people, age of 25 or 20 young people, this is more dangerous, because with the advancing age, the age like 60 or 70, like me, there may be lot of collaterals may have developed in elderly people, but young people, they have got the only basic coronary vessels, and there is no anastomosis there. So there is no anastomosis in the bigger vessels. In the smaller branches, there may be anastomosis amongst the different coronary vessels, and if the infarction occur in the area where anastomosis has occurred, so the outcome will be less lethal. It will not be lethal. But if there is no anastomosis, then the even smaller vessel blocked may cause the severe infarction, and death may occur. The normal cardiac muscles require 1.3 ml of oxygen per 100 grams of the muscle. This is the basic requirement of oxygen for 100 grams of muscle, 1.3. So normal supply, coronary supply, which we discussed it is 8 ml per 100 grams. This is sufficient, more than sufficient. That is, tremendous blood supply is there as compared to the requirement. Requirement is only 1.3 ml, but 8 ml of oxygen per 100 gram of muscle is there in the normal coronary circulation. So if there is some narrowing of the vessel, this is because 75 or 80 or even 90% of the blood vessel people have got, and they are living quite life. They only feel pain when there is angina. Angina occurs during exertion. During rest, there is nothing wrong. Even 90% of the blockage of the major vessel may cause no pain at all or no ischemia. So this is because of this excessive supply of blood in heart. So only 15 to 30% of the coronary blood is sufficient for the survival of the muscle. Normal requirement is this, but this is supply is this. So if there is some blockage, it may become 6 or 5 or 4 or 2, it is sufficient. So quite a large blockage may not cause any ischemic heart disease. But center of the infarct has, if there is some blockage, the infarction occurs, and the center, if the infarction starts in the center of that damaged area. So, but center of the infarct has zero blood flow, and cell death occurs in the center of the infarct. Subendocardial muscles are easily infarcted. We discussed in the previous lecture. Subendocardial muscle, they only receive the blood during diastole. And there is maximum contraction of the muscle may cause the damage to the reduced blood flow to the subendocardial muscles toward the inner side of the chambers of the heart. Acute coronary occlusion, zero blood flow or very low blood flow in that area, infarcted area, how the infarction is developing. And there will be, if there is infarction, there is ischemia. For ischemia, there will be more accumulation of carbon dioxide, adenosine, and vasodilator we discussed in the previous lecture. So vasodilatation with accumulation of these that in that area may occur. Lot of blood flow, vasodilatation occurs, and blood is stagnated. वहाँ पे कम होता है. And all the oxygen from that stagnant blood may be extracted. Heart can extract a lot of oxygen, so there will be deoxygenated blood there, and area become blue in that area. Damaged area become blue because of the deoxygenated hemoglobin. वहाँ पे oxygen कम होती जाती है, and increase permeability causes edema. So there is more vasodilators produced, vasodilatation occurs, and the edema may occur in that infarcted area जहाँ पे infarction damage हुआ है. The cause of death in myocardial infarction, it is because of the damaged myocardium, and the force of the contraction of the heart is reduced, and decreased cardiac output, which we term as this shock. Cardiac output is reduced, blood pressure is reduced, the person goes into shock. This is known as the cardiogenic shock. Something wrong with the heart, that is the ischemia, and the force of the contractibility and has been reduced, and this is results into the cardiogenic shock, one cause of death. The other is damming of the blood in the if there is left ventricular failure. Left ventricular failure may cause the damming of the blood in the pulmonary, because the pulmonary blood is oxygenated blood comes from the lungs to the left side of the heart. If there is left side failure occurs because of this, some damage to the left myocardium, so it may cause the damming of the blood in the pulmonary area, and pulmonary edema is the another very common cause of death in coronary artery disease or acute myocardial infarction. Then damaged area may cause firing, abnormal sequence of the passage of the cardiac impulse, or new generation of impulse from that infarcted area, what we term as the current of injury. It may cause the uncoordinated contraction of the myocardial muscle, which we term as the fibrillation. So fibrillation of the heart may occur, that is simultaneous contraction may not occur, different muscle may be contracting not simultaneously, so there may be fibrillation of the heart, and this is another cause of death. So coronary, this is cardiogenic shock or the pulmonary edema, and the fibrillation of the heart, and systolic stretch of the cardiac muscles, which we are going to see. When there is some damage to the myocardium, if some damaged area, if it is replaced by the fibrous tissue, collagen fibrous tissue, but that area become thin and fibrous, muscle fibers are scanty in that area, damaged area. When the heart contracts, that area may not contract. So that will stretch out, which we term as the systolic stretch, we are going to see in the diagram as well. Damaged area replaced by the fibrous tissue, that is thin area when heart goes into the contraction, so there is outstretch of this thin out area, and this may rupture. So rupture of the heart may occur. So systolic stretch or cardiac rupture may occur at that area. Ventricular fibrillation, which we see, this is ventricular fibrillation. Why the fibrillation may occur? That is, leakage of the potassium occurs at from the blood vessels, from the cells, damaged cells. If the cells are damaged, a lot of potassium may leak out, and this increases the irritability of the rest of the muscles. Leakage of the potassium and current of injury from that area. Previous slide में भी बोला था मैंने, current of injury, that damaged area is depolarized, and this depolarized may spread into the nearby muscles. So the current of injury, no repolarization in that infarcted area, that is constantly depolarized area, and constant impulse may be generated to different muscles, and the fibrillation may occur in that area. And then sympathetic stimulation If sympathetic stimulation occurs, that should occur if there is cardiogenic shock, if the blood pressure is reduced, and the normal mechanism to increase the blood pressure is sympathetic stimulation. So sympathetic stimulation further increases the irritability, and it may cause the more coronary occlusion and more blood ischemia may occur. So sympathetic stimulation increases the irritability of that muscles, and the fibrillation may occur. We are talking about fibrillation. Dilatation of the ventricle because of the failure. Left ventricle is failing. It will be dilated, and a lot of blood will be collected. It cannot pump. So it is dilating. Dilated blood vessel, there is the chance of abnormal conduction of the impulse, because the pathway for the impulse has increased. The total surface area that has been increased, and there may be fibrillation may occur. Coordinated or synchronous contraction may not occur in this dilated ventricle. So fibrillation will occur in these cases. Rupture of the heart, which we are talking about, that is dead muscle fibers, they degenerate. If there is some damage, infarction, that will be replaced. If the person survives, that will be replaced by the fibers, collagen fibers, and that is the thin area in that wall of the heart. So heart wall is stretched and thin in that area, and this area bulges out with each contraction. With each contraction, this area, which is muscles are not there, fibrous tissues are there, so this is not contractile, so it will bulge out. Diagram में अभी हम देखते हैं, we are going to see it will bulge out. So systolic stretch, this is known as systolic stretch, and it may cause this bulge increases with time. With the passive, each contraction it bulges out, and this bulge, size of the bulge increases with the time, and it may cause the rupture of the heart may occur. So cardiac tamponade may occur. Initially, if the rupture of the heart occurs, blood collects in the pericardium, which we term as the cardiac tamponade. So there is further enhancing the cardiac failure. This is the stretch. This when this damaged area has been replaced by the fibrous tissue. This area is thin. When heart goes into the contraction, it bulges out, and with the passage of time, this bulge increases, and it may rupture. It may rupture, and rupture of the heart. And this is the condition the person can die of a broken heart. The stages of if the infarction has occurred, the gradual. If the person survives, it is gradually recovery stage in the myocardial infarction is there. When there is small infarcted area, it depends. So if there is small infarcted area, there is no cell death, and it is complete recovery may be possible. But the temporary loss of function occurs in that area. But when it is recovered, if the infarct is large, this may be complete recovered. But if the infarcted area is large, in the center of that infarct may be complete death of the cell infarction, and in that area, so large infarct causes the central area necrosis. If the cell death occurs in the central area, that is permanently damaged. And immediately around some non-functional area, this is central area is necrotic area, cell death has occurred, and around that area there is some non-functional area which failure of conduction will occur. Contraction will not occur in that area as well. So conduction and contraction both will not occur in that area, and that area gradually is replaced by the fibrous tissue, as we talked about. That is systolic stretch that has been replaced. The damaged area has been replaced by the fibrous tissue. This is if the infarction occurs in the center, then there is non-functional area. Dead area is there, non-functional area is there, and mild ischemia around that area is there. So if this dead area is replaced by the fibrous tissue in the center, and the mild ischemia is there, and gradually this is the dead fibers are in the center, and the fibers around they can survive again, and this central fibrous tissue in the center occurs, the rest of the area may recover. So the small ischemic area, it will cause the temporary non-functional and no cell death, and almost full recovery occurs if there is small infarction and the blood flow is restored. And large ischemia may cause the central dead area due to the complete absence of the blood flow, as we saw in the previous slide in the diagram. And area around this is non-functional and fails to conduct the impulses. And the area around this is slowly contracting zone, where mild ischemia is there. So this is gradually recovering. So the stages of recovery from the myocard: replacement of the dead muscle by the scar, that is fibrous tissue laid down, scar is being formed. So the central muscle die very quickly, and that area enlarges in next few days, and the collateral restore the blood supply in the surrounding non-functional area. जो dead नहीं हुआ उस जगह पे gradually the collaterals will develop, or collateral will open, and the circulation may be restored in that surrounding area. But in the center, death has occurred. Cell death has occurred. Or after a few weeks, non-functional area starts functioning, because gradual, that is the restoration of the blood supply. So invasion by the fibroblast in the dead area, and the fibrous tissue grows in that area, scar, which we saw in the previous diagrammatic slide. Center में scar बन जाएगा, scar is formed. So progressive contraction and the dissolution of the scar to smaller size in months and years occur. That damaged area, gradually muscle grow around that, and that is gradually वो छोटा होता जाता है. So normal area around that area there, the normal myocardium around that area will hypertrophy to compensate for the loss, जो loss हो चुका है, the muscle loss. The rest of the heart will hypertrophy to compensate the loss. So normal area hypertrophies for the compensation. Then this is all about this. And what investigations, important investigations? We know that is ECG is the very important investigation for ischemic heart disease. So cardiac enzymes, different enzymes, they are this you will study in the medicine classes. That is LDH and troponin. Troponin is very important test. That is tested in acute infarction. This is raised, and then endocardiography, echocardiography, that is heart. Echocardiography will tell you the functions of the heart, and the treadmill exercise, that is exercise tolerance test, ETT. These are the different tests performed for the investigation of this myocardial. Then thallium scan, there is another scan which tells us about the coronary circulation, state of the coronary circulation, thallium scan. And coronary angiography. Angiography is done to see the blood vessels. If there is some damage, some blockage, that blockage may be relieved by the angioplasty or may be replaced by stent. So angiography is the. So ECG, common changes in ischemic heart disease. We discussed ECG as the depression, the current of injury, as the depression or elevation in the respective leads in ECG we will see, and T wave inversion may occur. We are going to see some slides. So Q wave is prominent in ischemia. If infarction occurs, acute myocardial infarction, Q wave is quite prominent. This is the rest normal ECG, and during exercise there is the ST depression is there. You can see that is during exercise. This will that is electrocardiographic changes during exercise test, ETT में. There is the depression or elevation of the ST segment. This is ST segment. This has been depressed there, and this is normal ECG before heart attack. Before this is normal ECG, and then minutes after infarction, you see there is the T wave, tall and pointed, and ST elevation. T wave is tall, pointed, and ST segment is elevated. ST segment has been elevated. So this is acute myocardial infarction, minutes after infarction. Then hours after infarction, gradual replacement of bellows dilatation, etc. What you have, the T wave is inverted. Now inversion of this is normal upright T wave. This is normal T wave. This is the acute infarcted T wave, that is the tall and pointed T wave. Now and ST elevation, and hours after there is the gradual inversion of this T wave. So T wave inverted, R wave voltage has been reduced. R wave voltage has been reduced. This much voltage was there, now the voltage has been reduced, and Q wave is gradually developing. There is no prominent Q wave in here. There is no prominent Q wave in the early stages of, but the after R there is development of the Q wave. Then the days after, that is gradually recovery has occurred. You see that is what has happened. ST segment returned to the normal. ST segment was elevated here and it returned to again normal ST segment, but Q wave persists. Q wave is there. इसमें और इसमें क्या फर्क हुआ? Q wave is prominent in this post myocardial infarction ECG. After days after recovery, days afterward, there is the Q wave present and T wave is still inverted. It will be T wave inversion and Q wave remain there for a long time. So weeks after, then you see weeks after T wave upright. Now T wave is upright and ST segment is there, but the only thing left is this prominent Q wave. Normal ECG, and this is prominent Q wave. T wave upright again, and ST segment is again not elevated, not depressed, but Q wave persists. So that is gradual recovery stage of the heart. So treatment, that is beyond our scope. But what is the treatment? Coronary dilators are given, nitrates are given, which cause the coronary dilatation, and then the beta blocker to reduce the heart rate, and the angioplasty, dilatation of the blood vessel if there is some blockage there. That blockage may be relieved by the dilatation of the blood vessel. उस blood vessel को coronary को अंदर balloon उसको stretch करके खोल देते, and then the stent may be placed in that area. Then finally, if stent is not possible, then the bypass surgery or cabbage जिसको कहते हैं, coronary artery bypass surgery is there. This is the scan, that is these are the normal coronary vessels. If there is some blockage, angiography is being performed to see the blood vessel. These are the angiographic blood vessels, and left this is LAD branch and the left main coronary artery and circumflex vessel. This is angiography. You can see the blood vessels. If there is some blockage, you will see. आगे हम देखते हैं diagram में देखते हैं. This is the coronary. This is blockage here. You see, these are the coronary vessels, but there is blockage there, and the ballooning has been done here. That is dilatation has been occurred and it has been opened again. So this is angioplasty has been done. Angiography and the ballooning is being done here, and it has opened again. This was blocked vessel, and this is a stent with which is placed inside. If you want to insert a stent in the constricted area, this is stent for the restoration of the blood flow. This is last, that is the coronary artery bypass surgery. That is, if there is some blockage in this blood vessel, this blood vessel is blocked, venous graft has been taken from the legs, and this has been aorta, base of the aorta to the beyond this blockage, this has been replaced. A new bypass channel has been grafted, and this is again, this block is replaced by this is, and then this is this plaque or the blocked area has been bypassed by this new vessel. These three vessels, graft has been. This is the coronary artery bypass surgery. So coronary artery bypass surgery is this: if there is some blockage, a vein taken from legs or anywhere from the body, that vein is from the base of the aorta to the area beyond that blockage that is there. But now, if possible, internal mammillary artery is there from a branch from the aorta, that is IMA, internal mammillary artery. that can be given grafted here beyond this graft. This is IMA. This is internal memory artery implantation, and this is the vein graft in this. So these are the coronary bypass surgery. So thank you very much. Next, we are going to talk about this cardiac failure. This is again long topic. I'll discuss cardiac failure in 2 lectures. So next lecture will be on cardiac failure. Thank you very much. Hope you are following me. If you have got some questions, some problems, you can ask me in the comment section, and that is the request. Finally, that is subscribe to my channel and share this video to rest of the students, medical students, so that maximum benefit can be achieved by this. Thank you very much.